Uh, I want to talk about irritability so that when someone like Dr. Tristel is designing his study again and thinking about visual analog scale, in addition to depression, anxiety, arousal, irritability may be one other thing that gets measured because that's probably the only goal I would try to achieve in this talk today. I'll start with talking about what is irritability. I think I like this graphic where it tries to put together a lot of different kind of related constructs together, like what is anger, what is irritability, what is impulsivity, what is reactive aggression, what could be impulsive aggression, and then separate from all of that is proactive aggression, right? So I think like the affective component of this irritability is really well recognized. And the definition that, at least in the field, commonly used is that irritability represents this low threshold for anger in response to frustration or in response to threat. So that really is important is that it's kind of like a response that something has to happen that then triggers, but it is an internal state. So that's an important aspect. And often in the pediatric literature, it has been described as tonic irritability, which is this mood state that is grouchy, or phasic irritability, which is the temper tantrums. I have a 6-year-old, so I can vouch to temper tantrums that can sometimes occur. So these two aspects are important. And irritability is important because in adults, it's not well studied at all. So I have tried to borrow some of this information from pediatric literature, and I have tried to come up with different, or at least follow the constructs that have been described in this context. Why is irritability important? This is a long table, but as you can see that it is included as a criteria across many different disorders, but it is very poorly conceptualized. And in that way, it is not that much different from anhedonia that we discussed, that we just heard about, right? So is irritability a mood? Is it a behavior? Unexplained irritability leads to the idea, is there some version of an explained irritability, persistent versus episodic? So I think these aspects are still very important to keep track of as we think about irritability, but it is not well understood, and more is needed to even like the phenomenon of irritability to be understood a bit better. Why my focus has been in the context of depression, where it's even a more unique symptom, that it's a criterion symptom of the major depressive episode in like less than 18-year-olds, but in adults, it's not. It has practical implications. If you look at commonly used scales like the 9-item patient health questionnaire, the adolescent version has irritability in it, the adult version doesn't. We at UT Southwestern developed the quick inventory for depressive symptomatology, or QIDS. And QIDS, in adult version, does not have irritability. The adolescent version of QIDS has irritability. So I think even whether irritability gets measured or not is an artifact of whether it was included as a symptom or not. But even like epidemiological studies and even STAR-D showed that about 40 to 50% of adults with major depressive disorder, they experience significant irritability during their current depressive episode. So I think that's, again, an important aspect to keep in mind. So how to go about measuring irritability? And that is an important question because we don't have good measures. And here we have used this measure that was developed by my mentor, Dr. Trivedi, in the context of when FDA came out with warning about an activation syndrome that precedes suicidal behavior along with initiation of antidepressants in depression. And so the scale was developed as the symptoms that go along with depression, and that's why it's called associated symptoms. It actually measures irritability, anxiety, insomnia, panic, and mania. But we landed on these 5 questions that we called irritability measures. These are, again, very simple statements that then people are asked to rate on a 5-point scale of strongly disagree to strongly agree. Now, why do I like that it is strongly disagree to strongly agree? That it differs from the symptom count measures like PHQ, where it's asked like, do you have these symptoms? Yes, no, and then if it is, then how many days? Even QIDS has that issue of asking about like whether the symptom is present or not. By rating on strongly disagree to strongly agree, we actually see variability that happens even in healthy individuals or people who are not so depressed. And that allows us to use the same measure across a broad range of people, but also across broad age range. We have now We haven't published it yet, but we have shown that the scale has similar psychometric property in 8 to 12-year-old as it has in 65 to 85-year-old. So we can go around using measuring irritability with this construct from pretty much from 8 to 95. At least that's what our data shows, that this has a similar psychometric property in there. So, like again, going from that idea of like grouchy mood, so this is probably capturing that kind of like a tonic irritability. But I like in the adults, we have looked at that phasic irritability aspect as anger attacks. And these were first described by Maurizio Fava and over 30 years ago as basically panic attack minus and replace panic with anger. And it was described as a syndromic construct that it has to have like irritability has to be present for 6 months, overreaction with anger, and presence of at least one anger attack within the past month. And as I said, the anger attack is basically a panic attack, but that what that involves is anger. So in addition to the autonomic arousal kind of symptoms, it also has like aggression symptoms, like feeling like attacking others, attacking physically or verbally, and throwing or destroying objects. So our work has looked at both the grouchy mood aspect of things with the measure of irritability, but also this anger attack that gets to some of those of like outbursts or phasing. So how frequent is anger attack? It seems, at least even in our data, it tends to be there in about a third of people with depression and maybe slightly higher. But various people have reported various different prevalence of anger attack. What's important about anger attack is that if you look at something like depression with insomnia or depression with anxiety, typically people who have major depressive disorder with moderate or severe insomnia tend to have higher overall depression severity. MDD with anxiety features, anxious features, always has higher depression severity overall as compared to those without. Whereas in the context of anger attack, those with or without anger attack, their levels of depression severity is almost identical. And this is not just us, but others have also reported that. But presence of anger attack is associated with higher irritability, higher hostility, higher anxiety. And we have shown that those who have more frequent anger attacks, they tend to have higher irritability and higher anxiety. So why go about measuring irritability is the next feature. And what we have shown is that if we look at a person's functioning, so this is a measure of social functioning, just the presence of irritability by itself, along with presence of depression, is independently associated with worse psychosocial functioning. So here we are using SAS-SR as one of the measures. We have shown it to be associated with worse quality of life, even after we control for depression severity. This was a study of individuals with stimulant use disorder. So presence of irritability in people with depression, people with stimulant use disorder, is associated with greater functional impairment and poorer quality of life at that visit concurrently. Others have reported that at an index visit, presence of irritability predicts higher likelihood of lifetime substance use disorder, lifetime anxiety-related disorders, and lifetime antisocial or personality disorder. But it has also been associated with greater impairment during long-term functional impairment, global impairment, impairment in work responsibilities, impairment in household duties, and impairment in poor quality of life. So I think this we can say that irritability we show cross-sectionally, others have shown longitudinally that it's associated with greater impairment and may be associated with poorer outcomes in the future. But we wanted to show whether irritability was associated with worsening of irritability was associated with clinical outcomes. And what we found first was that conventional antidepressants like SSRIs or even bupropion or venlafaxine, they worsened irritability in about 5% of people when they were started. And most of this worsening was happening during the first few weeks of treatment. And if people had any worsening during the first 6 weeks of treatment in their irritability, then it was associated with lower likelihood of remission at week 12. So just the very act that they had some worsening of irritability, it was associated with lower likelihood of being in remission later on. So we thought that this was a prognostic feature. So if we monitored irritability early during the treatment, it may help us make better treatment decisions. But that raises the question that about 50% of people with depression will have significant irritability. So yes, 5% have worsening, but it's much more likely that people will have improvement in irritability. And does that improvement in irritability prognosticate features? And that's what we looked at in the second set of analysis, where we looked at if people had greater by week 4, if they had median or greater improvement in irritability, at week 8, they were more likely to be in remission. So you can see that in one of the studies, those who had less than median improvement versus those who had greater than equal to median improvement in irritability, the likelihood of remission at week 8 was over twofold. And then it applied to another study, an open label study that we had, and also that they were more likely to have a meaningful benefit, so less likely to have no meaningful benefit. So we then wanted to take this and really apply it in terms of maybe using it in clinic. And we developed a very simple model equation. This is the only equation where we looked at 2 time points, 2 measures. So baseline week 4, depression and irritability. So quick inventory of depressive symptomatology was common across all the 2 studies that we looked at. So we just looked at baseline to week 4 change in depression, baseline irritability, and baseline to week 4 change in irritability. We used week 4 because our primary care work showed that the earliest someone can come back to see in clinic usually ends up being 3 to 4 weeks. Otherwise, in busy practices, that's often not difficult. And what we found was that what I don't show you is that baseline to week 4 change in irritability was predicting week 8 depression outcomes even after controlling for baseline to week 4 changes in depression severity. And then when we applied the model estimates from one study, COMED, it was replicating very well in a separate study. So we think that this could then lead to this kind of a calculator where in clinical practices, if we could ever get it integrated in an electronic health record, as a clinician, you can just put in, this is person's baseline depression severity, this is their baseline irritability, this is week 4 depression, week 4 irritability, and you can get to some of those personalized prediction that, for example, in this hypothetical case, this person's likelihood of remission at week 8 is 2.4%. So that would be a very strong case to be made for this person that let's do something different and not continuing doing the same that we have been doing for this person's treatment. We replicated this calculator pretty well in a third sample, so that was EMBARK sample. So we think that with this, if we are using measurement-based care paradigms, then that could allow us to integrate both measures of depression severity and measures of irritability, and that can help us make better prediction, about a 0.8 area under the curve. So fairly decent prognostic utility in that sense. But as we were doing this work, we were asked, after our paper was published in American Journal, Danny Pine had written an editorial asking us to look at developmental literature. And one of the findings there, which was pretty impressive, was that in the study of 6 to 12-year-old children, where annually their irritability, anxiety, and depression was measured, the presence of irritability was associated with higher likelihood of suicidal attempt or behavior during ages 13 to 17, whereas high anxiety and depression alone was not associated with that higher risk. High anxiety, irritability, and depression, that was the worst group, but just the presence of irritability itself was associated with higher likelihood of subsequent suicidal behavior. And then there were other studies where in this study, people were looked at during their adolescence and then reached back out 30 years later, and in the interim 30 years, just the presence of irritability at baseline was associated with higher likelihood of suicidal behavior. So we went about looking at suicidal ideation, and we looked at 3 items that are pretty specific to active suicidal ideation. So those are the 3 sentences that are there, and these are again rated from strongly disagree to strongly agree. So we looked at it in 3 separate clinical trials, and these all 3 trials had very different design. One was an open label, EMBARK was a biomarker study, COMED was combining antidepressant monotherapy versus antidepressant combination. So we decided to look at these 3 studies separately. And again, all 3 studies had fairly decent sample sizes. So 665 people in COMED, 296 in EMBARK, and 266 in SAMS. So what we found was that if we just looked at how does irritability at visit today relate to suicidal ideation at today's visit. At least numerically, irritability and suicidal ideation were more, there was a stronger correlation across the three studies as compared to, say, symptoms of anxiety and suicidal ideation, symptoms of insomnia and suicidal ideations, or symptoms of other symptoms of depression and suicidal ideation. I'll be remiss if I don't point out that in these overall depression measures, we took out the suicidal ideation related item because otherwise we would be double counting suicidal ideation on both sides. The question then here was that is irritability predictive of concurrent suicidal ideation even after we control for depression severity? And that's what we found, that in all three studies, irritability was associated with active suicidal ideation even after controlling for overall depression. And in 2 out of 3 studies, actually the other symptoms of depression were no longer predictive of suicidal ideation when we accounted for symptoms of irritability. So again, could be pointing out that at least in concurrent symptom, irritability may have a stronger association with suicidal ideation as compared to other symptoms of depression. We had a similar finding in a study of stimulant use disorder that again, irritability and suicidal ideation were more strongly associated as compared to depression and suicidal ideation. And we find again that it was 2 to 3-fold stronger association between irritability and suicidal ideation as compared to other symptoms of depression and suicidal ideation. I'll switch just a little bit and talk about how anger attacks were also associated with concurrent suicidal ideation. So people who are reporting having anger attacks, they had higher suicidal ideation. And here, irritability was also associated with higher suicidal ideation. What was in this study in EMBARK, where we had anger attacks, what we found was that people who had 9 or more anger attacks in the preceding month coming into the study, their suicidal ideation was pretty much at the top of the scale. The scale goes from 0 to 9, and these people were reporting almost 9 on that scale. So it was really strong how there was kind of like this increase in suicidal ideation severity with the more frequent anger attacks that had been reported. We also found that those who had anger attack at baseline versus no anger attack at baseline, there was a significant difference, even though with treatment, suicidal ideation generally improved consistently over 16 weeks of treatment. Those with anger attack, these are just raw means that are reported here with standard errors. And there was a significantly greater, at least a moderate effect size difference full 16-week of treatment. Just a single feature of presence of anger attack at baseline was predicting this persistently elevated levels of suicidal ideation despite 16 weeks of treatment. So again, showing that irritability, anger attack is predictive of suicidal ideation subsequently. And that's what these results kind of highlight over there. But really, our interest was that is irritability a potentially modifiable risk factor for future suicidal ideation? And that is what we tested here by looking at changes in irritability, because we had published before showing how irritability was changing as soon as by week 2 and week 4. So here we looked at baseline to week 2 change, so that is delta. And what we wanted to predict was suicidal ideation over the 6 subsequent weeks. So this is going from week 2 to week 8. So really early changes in irritability and early changes in depression, predicting levels of suicidal ideation subsequently. And in all 3 studies, that baseline to week 2 reduction in irritability was associated with lower levels of suicidal ideation from week 2 to week 8, even after controlling for that baseline to week 2 changes in overall depression severity. And again, consistent with the previous findings in EMBARK and SAMS, we see that when we account for changes in irritability, changes in overall depression are no longer predictive of subsequent levels of suicidal ideation. So this is, again, interesting that across 3 studies, we find the same thing. And when we control for, say, instead of overall depression, we control for insomnia or anxiety, these findings were exactly the same. And we find the same thing in the study of individuals with stimulant use disorder, that greater reduction in irritability during first 2 weeks of their exercise treatment was associated with continued lower levels of suicidal ideation, not only from week 2 to week 12, but from week 12 to week 36. So this reduction in irritability early in their treatment was prognosticating lower levels of suicidal ideation up to 9 months out, so 8 to 9 months out. So that's really one of the stronger findings that we see. So just to summarize the information here, that as irritability relates to suicidal ideation, we see that irritability is associated with suicidal ideation concurrently. Maybe this association is stronger than that of other symptoms of depression and irritability. Baseline irritability and anger attack predict future suicidal ideation, and irritability may be a potentially modifiable risk factor of suicide-related outcomes. I have to say very carefully that we have only looked at suicidal ideation so far. Now we finally have some data from some youth network studies where we are looking at, again, irritability predicting suicidal events. So suicide attempt or worsening of suicidal ideation. I don't show you the data, but we have now findings showing that irritability is a predictive of suicidal behavior also in these data sets. So very quickly, moving on to some treatments for irritability. There are only two FDA-approved treatment indications, which is irritability with autism spectrum disorder. That's where aripiprazole and risperidone. Off-label stimulants have been used in pediatric irritability, and I'll talk to you about these different other medications in this context. So in COMED trial, we showed that on average, there was reduction in irritability, about 25% reduction in irritability. There was no difference amongst the three treatments, SSRI alone versus bupropion plus SSRI versus venlafaxine plus mirtazapine. They all improved irritability. And the effect size in improvement in irritability after taking out the effect of overall depression was about 0.36. So a moderate effect size specifically to reduction in irritability. A drawback of all these three samples was that there was no placebo arm. In SAMS, again, a similar reduction in irritability with open label SSRI treatment. So EMBARK had placebo as a comparator. So we see that a similar sertraline, there is an average of 27.9% reduction in irritability going up to week 8. And the effect size in EMBARK as compared to placebo was 0.56. So definitely a moderate effect size reduction in irritability with sertraline as compared to placebo. And this was actually unchanged even after we controlled for, say, like changes in HAM-D over that period of time. Brexpiprazole, again, these are other data that have been published where open label augmentation with brexpiprazole resulted in reduction in irritability. And when Brex was discontinued, it led to an increase in irritability in this sample. I was involved with the study of pimavanserin, which again was being studied for depression. And in this phase 2 trial, at least there was a moderate effect size. It's a bit coincidence that our effect size was 0.56 in sertraline versus placebo. And in the study of pimavanserin versus placebo, pimavanserin augmentation was associated with a very similar effect size of 0.56. So again, there may be some evidence for these medications may having some potential utility in improving irritability. James Murrow has done some of the ketamine studies at Sinai, had done this very small study of ketamine versus midazolam for rapid reduction of suicidal ideation, a transdiagnostic sample. Visits were done at day baseline, day 1, day 2, day 3, and day 7. So why I looked at this data is that this study actually had the same measure of irritability that we have looked at, so concise associated symptom tracking scale. And we also had depression severity, which was MADRS, so we could actually control for that. And we can look at the changes in irritability and how it relates to suicidal ideation. So what we found was that with just a single infusion of ketamine, there was a big reduction in irritability early on. So the effect size, again, is a 1.01. So ketamine seems to have this massive reduction in irritability as compared to midazolam. And this effect size was there even after we controlled for MADRS. So ketamine may have some unique effect of improving irritability that's independent of its effect on overall depression severity. we found that baseline to day 7 changes in irritability were very strongly correlated with changes in suicidal ideation. So now here is the fifth data set where we see that the association between irritability and suicidal ideation is there. And then these data come from an open label study where anxiety, irritability, and agitation was looked at in this ketamine, open label ketamine infusion, Canada. And again, there with a single item measure from GAT-7, they showed that individuals who started with anxiety, irritability, and agitation, use of ketamine was associated with significant reduction in irritability during that period of time. So that's talking about irritability, anger attacks. Again, antidepressants have been shown to improve anger attacks, but 7% people treated with fluoxetine had developed new onset anger attacks. Again, underscoring the same findings before with irritability, that antidepressants in general improve irritability and anger attack, but in some people, in a small proportion of people, they may actually worsen. So that 5 to 7%. Other studies, bipolar depression, use of citalopram along with mood stabilizer seem to have led to seized anger attacks. So the medications that we commonly call antidepressants, they have this maybe somewhat effect on irritability and anger attack. We also know that they help with anxiety also. There may be some role, but with some caution that in some people, they can actually worsen irritability, they can worsen anger attacks. So just a summary of that here, we know that there are no FDA-approved medications for irritability in adults. And part of the challenge is that we do not measure irritability in any of the FDA-approved studies, except a few people, a few studies. If we are treating people, monitoring irritability has the potential for prognosticating their longer term outcomes. If you're using antidepressants, we have to be aware of the potential for future worsening. And I bring up ketamine here because it could potentially be a probe where we are, if we are doing the kind of study that Dr. Crystal just presented, we could potentially start looking at brain circuits in a bit better fashion, where what are the brain circuits that relate to changes in irritability as compared to when Dr. Crystal was presenting about changes in depression versus anxiety. So we can then start to understand that a bit better. So with that, I want to underscore that this is not a single person's work. This is a team effort, and also thank researchers and participants of studies that I talked about, like COMET, EMBARK, SAMS, and STRIDE. These studies were, again, multi-site study, a lot of people involved.